Hey, everybody, you have reached the Farmland podcast. This is Bradley Nelson, and as always, I'm joined by my colleague, Tom Davies. Say hello, Tom.
Hey, listening audience. Glad to be back.
Awesome. Now, today we actually have a very special guest, but before I
Esteemed.
reveal who that esteemed doctor is, yes, this is a doctor on this call. The topic of our conversation today is really the pharmacy universe in flux, how state regulations and reforms are really reshaping the industry. So we're going to take a really high level approach and look at the state legislative landscape and really have our guests come in here and lay it down for us. But first, I just wanted to give an intro for Farmland. We've been here for a while, been doing this for a little bit, and we just want to remind you that we are always here to serve up the freshest pharmacy information and insights to benefit advisors, employers, and anyone else looking for better understanding of the pharmacy industry. And we will take the biggest topics and dig deep, offering perspectives you won't find anywhere else. And as always, Farmland is brought to you by RX Benefits. So, Tom, tell us who our host is and what we'll be talking
Exciting
about.
stuff, right? Today we're joined by Wes Hill, Senior Director and Managing Counsel here at RX Benefits, who is an expert on the impact of regulations and legislation in the pharmacy industry. Wes, we're super excited to have you.
Tom, Bradley, it's an honor to be here with you today to discuss my favorite topic, which is state PBM regulation. And it's been busy, so I think we've got a lot to talk about.
Awesome, Wes. And I mentioned to everybody, this is a doctor, but he is a juris doctor. So don't mess with him. You might get sued. So when it
Well,
comes down to this, one of the things that we'd like to look at here is there's a lot of reforms going on at the state level, right? They're trying to bring transparency, reduce costs. There's a real focus on independent pharmacies, but there's a lot of challenges with that, right, Wes? So can you just kind of tell us a little bit about what's happening at the legislative and regulatory level, and what kind of scrutiny has the PBM industry been under recently?
And and Wes, what's really driving this? What's driving these conversations? I've been in managed care now for 20 years, and I don't think I've ever seen a marketplace landscape with more attention specifically on PBMs than I have in the last couple of years. So what's driving these types of conversations?
yeah, Bradley and Tom, those are great questions. I would start out by saying that, in January 2025, the states opened up their legislative sessions, right? That's when the elected representatives come together, the Senate, the House, at the state level, right, introduce legislation and then vote on that. It eventually makes its way to the governor, right? So if you remember Schoolhouse Rock, think back to that, how a bill becomes a law. That's what we're talking about. So that's what we're in the middle of now. And I would say, at the time of this recording, right, our team is tracking 1,400 plus bills at the state level
Wow.
that touch in some way on the prescription drug benefit. And then so that gives you an idea of the volume, right? There's a lot going on at the state level right now. And then, Tom, to your point, like looking at this over time, right? You've been in the industry, like you said, 20 plus years. I would say that the volume of bills increases every year. So a few years ago, we maybe were talking about the hundreds
Mm-hmm.
in terms of prescription drug benefit legislation. Now we're in the thousands, headed towards 2,000 plus in the legislative session. Now, of course, the vast majority of those bills do not pass. But just the fact that so many bills are introduced tells you that it's a hot topic. For a little known, I think, industry, if you ask the man on the street, what's a PBM? Do you think most people could tell you what the acronym means or even who their PBM might be? I bet a lot of people couldn't.
Yeah,
Um,
peanut
but
butter and
like you said,
mayonnaise, right?
Yeah.
that's right. That's great. What a great combo. So, Tom, to your point, I think what's pushing on this, number one, I do think, right, we hear the complaints about the rising costs of healthcare generally. And then we also more specifically hear about the rising cost of prescription
Yep.
drugs, the out of pocket that the consumer has to pay at the counter when they go to fill that prescription. So I think we're hearing a lot of outcry bubbling up from that level. When that happens, right? Who hears about that? Prescribers hear about it. Pharmacists hear about it. Elected representatives hear about it. Um, and so they've gotten the ear of the industry. And then um, I would say, just thinking through it, right? We've got a lot of pharmacists and prescribers that are interested in this topic. We've also got pharma that's interested in the topic. We have all the other players in the prescription drug supply chain that are interested in the topic, and everyone kind of has their own position on PBMs and prescription drug benefit regulation. And so all of those people are introducing bills or going to their elected representatives and saying, hey, I think it would work better if we did this.
Yeah.
We regulated this piece of the supply chain more. So I think that's what we're saying.
Right. I think that the drug cost call out is something that is definitely a hot topic, right? If we look at drugs that were approved in 2021, the annual price was about $185,000 in 2023. And I know I've spoken to this on previous podcasts, but it's a helpful reminder. In 2023, it was a little over $300,000. So we start talking about these big numbers. I like to put them in perspective. So the average cost of a new car in 2023 was $49,000. The average household income in 2023 was $80,000. So when you start talking about the high cost of these medications, right, you can really see how this is driving some of these conversations. It does feel like to me a little bit, Wes, that there's a lot of finger pointing going on. That it's not the PBM, it's a pharmaceutical manufacturer, and vice versa.
Right.
Do you get a similar
Right.
impression?
I do. If you get into government affairs and you start visiting, right, your elected representatives, you start having these conversations with them and other players at the table, you do see a lot of finger pointing, right? So pharma is pointing at the PBMs right now, very publicly pointing at the PBMs and saying, this is the reason why prescription drug costs are so high. On the flip side, PBMs are pointing at pharma and saying, you set the list price of the drug. You literally control the price. So why are you blaming us? Meanwhile, you've got the patient who's, I think, kind of stuck in the middle. And then enter in the pharmacists who dispense these drugs, right? They have to acquire these drugs, stock them in their pharmacies, and then dispense them, and then at the same time still try to make a profit. And they're pointing at, I think, everyone saying, this is too expensive. And then to PBMs, it's, I'm not being reimbursed enough. So now I'm going to go complain to the legislature to get a better reimbursement. So yeah, everyone's pointing the finger at everyone else. And I think if you watch the hearings, the public hearings, for example, at the federal level or at the state level, where they take testimony from different players in the industry, what you often see is that the legislators conducting the hearing throw their hands up in the air and say, this is too complicated. It's too complex. Everyone's blaming each other. What are we going to do? Right? So it gets confusing fast, I would say, with all the finger pointing.
It certainly does. So Bradley, we talked a little bit about drug prices, right? If we focus like many others are on some of the behaviors of PBMs and some of the concerns around PBMs, right? There's a lot of talk and discussion around transparency and rebates, spread pricing. How is that playing a role?
That's actually a great topic, Tom. When it comes to just kind of piggybacking on what Wes was mentioning, a lot of what's happening from the hearings at the federal level, a lot of times that is really the public infighting of pharma versus the PBMs. That's typically where that happens. But what Wes also mentioned is the pharmacies that have the reimbursement issues. That is typically have the infighting that's happening at the state level. So you mentioned the word spread pricing, and so it's very important for us to talk about what that means. So pharmacy reimbursement and pharmacy payment is a two-sided ledger. So plan sponsors, carriers will pay a PBM a set amount of dollars for the drug span. But that's one side of the contract ledger. On the other side, you have the PBM working with the pharmacy and saying, you've agreed to this reimbursement model. So if there is a delta between what you charge your employer group here and you have, this is what you pay the pharmacy here, this gap right here that the PBM pockets their profitability, that is called taking spread. And what creates an issue, at least on the state level for a lot of pharmacies that are independent, that aren't part of chains, they can't purchase things in a certain way to bring their profitability. So that oftentimes they're reimbursed below their actual acquisition cost. And just to put that in perspective, since just between the 10 years between 2010 and 2021, there have been suggested over 26,000 pharmacy closures in the United States. And that can include chain pharmacies. So in 10 years, now, of course, you have some reopening and opening up, but even just in the last 5 months, you've got over 300 pharmacies in the United States that have closed their doors with nothing to backfill them. And this has become a real problem in potentially creating pharmacy deserts at the rural level, and why there's a lot of concern at the state level. And I bet you Wes has a lot more in terms of how those pharmacies are fighting back and how state regulations is reflective of that fight.
Yeah, that Bradley, that's a great point. We do see pharmacists fighting back, right? Like you said, they feel like they've been the recipient of kind of a raw deal in some of these PBM network agreement contracts that they've negotiated over the years. Whether you're talking about spread pricing, network adequacy, the ability of independent pharmacies to get into some of these preferred PBM networks, right? You've probably heard about steering practices, things of that nature. All of these deal with the networks that PBMs negotiate on behalf of the plan sponsor clients. And so at the state level, the pharmacists are very well organized. And so I would commend them on that, right? Everyone should be well organized. And so they do a good job voicing these frustrations with their representatives and kind of saying, look, um, we think there's an unfair advantage here, right, when it comes to community pharmacies, independent pharmacies, and we need regulatory intervention. And so what we've seen at the state level over the past few years is a focus on the ability of community pharmacies to participate in these networks, right? So a few classic examples of that. One is a type of law that's been on the books for years, in the fully insured environment, but in the PBM kind of self-funded space, it's a bit newer, but it's called an any willing provider law, right? And that type of law would say to the network administrator, in this case the PBM, you have to admit any willing provider, in our case a pharmacy, into your network if they will agree to the standard terms and conditions. So you cannot arbitrarily exclude, right, an independent pharmacy, a community pharmacy, if they're willing to agree to the terms. So that's a classic example. Another example we've seen, right, is so once the pharmacies get into the network, they're then concerned about members being able to come to their pharmacy, right, on an equal footing with every other pharmacy. And so we've seen adoption of a type of law called steering or anti-steering, which says that the PBM, in some cases, the plan sponsor cannot steer a member to a particular pharmacy. So that might be requiring them to use a particular pharmacy to receive a certain type of drug, for example, or a certain day supply of drug. There's also incentives, right? You could see differing cost share to use a particular pharmacy, maybe mail order versus retail. And so the pharmacists have lobbied, and I think very successfully, their representatives to say, look, we want an equal, fair playing field within networks, no steering to PBM-owned pharmacies. We want members in their communities to receive care right from their local pharmacist. So, Bradley, that was a great call out. So we've seen them be very successful at the state level in the last several years on those issues.
Well, I know in our state, Wes, it's probably no secret, Wes and I are from the Southeast. In our state, we did have an Alabama Senate Bill 252 that targeted steering practices specifically. And that was just one aspect of where there was a problem. But Wes, I'd like to get your take on a couple of things regards to anti-steering. So one, is a university applicable to any and every type of employer-based plan? That would be my first question. And number two, how enforceable is it?
Okay, good question. So for number one on enforceability to or applicability to different plan types, that's been a gray area over the last few years. And here's what I'd say. Let me back up a little bit. In 1974, I want to make sure I get my years right. We had the federal ERISA law that was passed. ERISA contains a doctrine called preemption that essentially says if you are a group health plan that is subject to ERISA, you're not subject to state law in most cases, right? Federal law applies to you. You can safely ignore most state laws that would interfere with the way you run your group health plan. Okay. And that's been on the books for decades. That's been a very kind of sound general rule of thumb that benefits lawyers have used in their practice for a long time. So as a result of a lot of the lobbying efforts, right, done by pharmacists at the local level, we saw state laws come in and that were then applied to ERISA plans. And we saw some legal action on that over the last few years. In fact, one case, very well known, the Rutledge case from 2020, that went all the way to the Supreme Court. The Supreme Court brought back unanimously kind of an unexpected answer, and that was, hey, certain types of state laws, like PBM rate regulations, so what we just mentioned, Bradley, how PBMs reimburse pharmacies, actually the court said those aren't subject to ERISA preemption. You could go ahead and apply those to an ERISA plan. So I would say a fairly narrow ruling, but after that happened, a lot of states and then their legislatures, when introducing the laws, and then at the enforcement level, the administrative agencies, usually Department of Insurance, said, oh, look, the Supreme Court said that when it comes to PBMs, we can now look through and regulate the ERISA self-funded plan. And so that's kind of set up a conflict that has created a gray area. So certain states, we know that there's more enforcement activity than others, certain hot states out there. And one of those, Oklahoma, I don't think it's any secret, they have aggressively enforced their PBM statutes to even include self-funded ERISA plans. They have a case pending right now before the Supreme Court. That's PCMA versus Mulready. And that case is at the Supreme Court now. And it's, Bradley, going to the question you just asked about enforceability of these network restrictions. That case will be looking at that now. And so it's still in the briefing stage. We don't have any type of decision on the merits. So we're kind of in a gray area waiting to hear what the court will say on that. So when it comes to steering, I think in the past, everyone thought we're steering in any network restrictions, right? Everyone thought, oh, ERISA preemption, right? We don't have to abide by that if we're a self-funded ERISA plan. So we'll wait to see what the court says on that for sure. But until then, we're in a bit of a gray area,
So
unfortunately.
you mentioned Mulready out of Oklahoma pending, and Rutledge kind of opened the door. Where was Rutledge?
Rutledge is out of Arkansas, so that's
Tell
another
me about that state,
hot.
because that state tends to be a little hot bit of activity when it comes to legal type of ramifications for pharmacy.
It feels like they've taken that anti-steerage piece a step further to me with
I
the
think you're right.
recent Arkansas bill, Health Bill 1150.
Yeah, maybe
That's right.
anti-competitive?
It's a great point. So, Tom, yeah, I think you're right. Arkansas, I would say they've been kind of the tip of the spear when it comes to PBM regulation. I mean, they were really out front early. They took that Rutledge case all the way to the Supreme Court. And then this legislative session, just recently, they signed into law HB 1150. And that law, it's interesting. It has a big impact on networks, but it's coming at it from a different perspective. It's not regulating the PBM and saying you can't do this or that activity in your network, right? What HB 1150 is targeting is vertical integration. And so that's the concept, right, of a PBM being owned or owning a health insurance plan who then owns its own pharmacy, maybe other types of
Or,
providers,
or
right? And we're
physician
seeing
practices.
exactly. So what we're seeing is right the stacked or vertical integration of companies, and that's very common right in the marketplace today. It wouldn't have been as common right in a generation ago, but today that's the environment we're in. And so again, I think as a result of the local pharmacies who have said, hey, look, we've got kind of unfair competitive situation here. They've lobbied their legislature and said, here's what we'd like to do. We'd like to say that PBMs cannot own a pharmacy in the state of Arkansas. So that's what HB 1150 is doing. It disallows PBMs and their affiliated companies from holding a farm, to be more technical, from holding a pharmacy permit in the state of Arkansas. And that also includes a mail order.
Yep.
Right. So we know that PBMs often operate mail order pharmacies that would be out of state, and then they mail in usually 90-day supplies or more type prescriptions to residents.
And
So mail
specialty
order
pharmacy, right?
pharmacies are they're in scope.
Specialty pharmacy too?
That's right. The bill doesn't, to my knowledge, call out specialty pharmacies, but the definitions are broad enough, I think, to encompass all channels. So retail, mail, and specialty are all in scope of this bill. So, and, yeah, I think it's a first of its kind piece of legislation.
And I didn't realize it was that broad. I just automatically went to CVS and the CVS pharmacy relationship. I didn't realize.
That's a great point.
Yeah, went to the mail order side. And Wes, you said specialty pharmacies were not included in this, or they were?
I'm sorry. So it's not called out in the
Gotcha.
legislation. So it's broad enough to include any pharmacy, right? So we often would think about CVS, right, being a PBM that operates a retail pharmacy. But because they specifically added in the piece that said, oh, and this also includes mail order, now we're capturing the out-of-state PBM mail order pharmacies. And I would also argue the out-of-state PBM specialty pharmacies that mail in
So
prescriptions.
Tom, what would you think would be a ramification of,
And I think that's a great point. It feels like to me there's a lot that at the state level, it's really a hotbed of discussion around these specific topics: transparency, drug pricing, access, right? And there's additional legislation out there, some coming from the prior authorization world. I know there's additional legislation with regards to utilization management. But before we jump into the potential risks and benefits of some of this legislation, the pros and cons, why, Wes, do you believe that there's been so much activity, so much fruitful activity at the state level, but at the federal level, it feels as if we've had these conversations and they just don't seem to go anywhere? I mean, there was a lot of topic around the funding bill in late December and the impact to PBM secondary to the information that was included within the funding bill. And then in the 11th hour, all of that was stripped out. So why do we just not see the momentum at the federal level that we are currently seeing at the state level?
Yeah, that's a great point, Tom. I think for years now, right, we've seen PBM kind of reform policies introduced at the federal level. Senator Grassley's been a leader on that for years. And despite these bills being introduced, they always kind of die,
Yeah.
right? Sometimes at the 11th hour. And I think, what we see then is when the federal government doesn't act, a lot of times the states will kind of take the lead, pick up the banner, so to say. And on some issues, it's been different. Like I would say on privacy, especially healthcare privacy, right? Federal government kind of led on that with HIPAA, and then we get lots now of privacy laws coming out at the state level.
Yep.
But this one's flip-flopped, right? So on PBM reform, PBMs are virtually unregulated at the federal level, at least in the commercial market. And so I think we've seen states say, at least based on their circumstances and the feedback they've received from their population, they've said, we've had enough and it's time to regulate PBMs. And they generally do that they start with a licensing framework, right, or a registration framework where they say, all right, let's find out who's operating in our state. If you want to operate here, you got to get a license.
Yep.
And so after that happens, then they'll start, wading in more to the different issue areas like pricing, which we've discussed, networks, right, which we've discussed, PBM rebate practices, right, and then Tom, you also mentioned utilization management. I would say year over year, utilization management continues to have the highest volume of bills, for example. I think that surprises a lot of people. Out of the 1,400 or so bills I mentioned earlier, we've got 200 plus focused on some aspect of utilization management. So
That's the
after we get
physician
the
lobby.
licensing, we dive into those deep issue areas. Yeah, go ahead, Bradley.
I was
Sorry.
saying that's the physician lobby. So the pharmacy steerage and reimbursement comes from the pharmacy lobbyist of the state, whereas the utilization management, prior authorizations and things, that comes from the physician lobby in the state. So I know that in
Gotcha.
some cases, it's not just PBMs, it's also the medical PAs as well, that is under some of these scope for utilization management. So it's always interesting, is all I got to say, and it's never dull.
Speaking of always interesting and never dull, before we transition to kind of the what does this mean, right? The discussion we've had thus far, Bradley, I think you have a news of the weird you'd like to share with us.
Yep, this is the part of the segment that Tom cringes at the most
Every time.
every time,
Every
because you
time.
never know what's going to come up, right? So I decided to kind of go back to my roots. We talked a little bit about Alabama and where I'm from, where Wes is from, and I decided to pull up a news of the weird from the state of Alabama. This is something that people might not know about, and what you might think of really is more of an Australian problem. But just a few weeks ago, actually, maybe just even a few days ago, Wes probably remembers this. We actually had a kangaroo incident in our state where a runaway kangaroo actually started running down a stretch of highway that runs between our state capital, Montgomery, where all the legislation happenings occur, and Atlanta, where all the Georgia state legislation occurs. So for some reason, you have this kind of kangaroo court going on in the middle between the kangaroo courts. But yeah, I thought that was a really interesting aspect there. And it was actually between Montgomery, Alabama, and Auburn, Alabama. So I think Wes, maybe the Auburn football team is really trying to up their recruiting efforts for 2025. So I thought that might be part of it. But here's the good news. Well, the bad news is nobody believed it at first when they called 911, but they ended up shutting both sides of the interstate down, and they had to spend a long time to try to capture it so it wouldn't get hit. So the interesting thing is that's not really something that you see in Alabama every day. But at the same time, it came out with a good story. But I did think it was legislatively appropriate because, well, it's between two legislative centers of excellence in the Southeast.
You're a
Bradley, I
wizard
have
at
so
this,
many
Bradley,
questions.
at weaving these two disparate topics together.
Hey,
A
you got to work
wizard.
with what you got, man.
Yes, I do appreciate the Auburn football reference as well, because we do know that out of all the marsupials, kangaroos are the most athletic. So
This is true.
at the very least, they picked the right one.
Absolutely. So I know there's a little bit of levity. We always like levity. So let's see how this plays out. This legislative stuff plays out. The non-kangaroo court standpoint. So what does this really mean to plan sponsors, and why should they care? Got any thoughts on that, Wes or Tom?
Yeah, I could jump right in on that one, Bradley. So it's a really good question. Number one, I have so many questions about the kangaroo story, so I'm going to go look that up later. That I want to know where it came from and how it got out there, but okay, I'll leave that for later. But so when it comes to the law, um, what I would say about let's take the most recent bill. I think this one's really interesting out of Alabama. Again, that's SB 252, which has an effective date of immediately, except for a few provisions that will go into effect later in the year. A lot of this bill actually goes into effect immediately. So that's one thing that's interesting that we see across a lot of these states. They will enact the PBM regulations as an emergency measure, and it goes into effect now, really without much time for the industry to respond or even plan sponsors to review the bill and understand it. So that's one thing about the bill I think is interesting is the immediate effective date of some of its provisions. Another aspect I think that's interesting that we haven't seen as much of, and that I think maybe Alabama is leading on this issue, taking into consideration that SB 252 was kind of a compromise bill. There were earlier bills, a bit more stringent, that were introduced that were kind of defeated, and then SB 252 were rolled out as a compromise that I think everyone could live with. So what we saw was plan sponsor optionality. That's what I like to call it. And so when it comes to the network restrictions or steering practices that we talked about earlier, when it comes to the use of spread pricing in the PBM contract, again, we mentioned that earlier. And then when it comes to the way rebates are handled, we haven't quite talked about that one yet, but that's another hot topic in the PBM industry, right? Or rebates. For all three of those topics, the Alabama bill built in a provision that I think plan sponsors should pay attention to closely, and that builds in optionality if the plan sponsor wants those kind of traditional PBM networks, traditional PBM pricing strategies, and traditional PBM rebate strategies. They could require that in their contract, and the law actually allows for it. So I would call that out as a piece of interesting, kind of legal development out of that bill that we don't see. Usually it's just a mandate that comes from the state, right? You must do X or you cannot do X. Here it's don't do X unless your plan sponsor requires it. So that's something to think through. One other aspect of the Alabama bill I would call out for plan sponsors is this idea of reimbursement mandates or rate regulations. We touched on that a bit with the Rutledge decision that directly ruled on that issue. That was out of 2020. Unanimous Supreme Court. Let me just say that again. Unanimous Supreme Court decision. We
Wow.
don't see a lot of those
What?
saying that ERISA does not preempt PBM rate regulations. And so Alabama has a rate regulation built into the law, and it says that for prescriptions filled at community pharmacies, the reimbursement will be equal to or no less than the state Medicaid rate. And that's pretty common. We see that floated
Mhm.
at the state level a lot. It hasn't passed in very many states, just a handful, really. But Alabama is the most recent state to pass that. And so what you're going to see now are the ingredient cost of the drug will be reimbursed at, I believe it's called, is it Alabama acquisition cost, Bradley, that we use for Medicaid here? It's an average acquisition cost calculation. And then there's also what's called a dispensing fee or professional dispensing fee paid to the pharmacy, right, for the service of dispensing the drug. Now, that fee is a little bit higher. That fee is going to be $10 or more. I believe in Alabama it's going to be, is it 1049? Does that sound right, Bradley?
1064. You were
1064, that's the
close. You're only
number.
out by 15
I
cents.
was close, but not quite on the money. So 1064 in Alabama. And so Tom, Bradley, you might have some data on this, but that's a bit higher than most commercial group health plans are able to negotiate with their PBM when it comes to a dispensing fee paid under the contract.
Yeah.
A good bit higher.
Yeah, and I think this is we understand oftentimes the intended consequence of this type of legislation. I think, Bradley, what would be the unintended consequence associated with it potentially?
Yeah. So from an unintended consequence, if I'm a plan sponsor, I have to look at my data and see what I'm spending on it. If I'm spending most of my money on generic medications, I'm used to a spread pricing, right? So if I go to a guaranteed profitability for the pharmacy side,
Yeah.
and I don't have some sort of pass-through pricing mechanism built into my contract, I could pay more. Because if you have a spread pricing with a guaranteed profitability on the pharmacy, that's just going to increase, right?
Yes.
So if you have a lever that you can pull down and say, oh, I want pricing just to be more of a pass-through. What I pay you is what you pay the pharmacy. I'm still going to pay more because I'm paying an acquisition cost plus a dispensing fee, plus more than likely some sort of administrative fee that the PBM is going to distribute. So while pharmacies can say, oh, it's not going to increase your cost for a patient at the point of sale, more than likely that is true. However, what's not necessarily discussed in these types of bills is that cost isn't just absorbed by PBM. Somebody pays the PBM. So
Yep.
ultimately, that cost will get passed on to the employer groups that pay them, the carriers that pay them, which will translate into higher premium cost for employees and their dependents. So if anybody tells you that the money's just going to disappear from somebody's balance sheet, I think that is wishful thinking and a hope-based strategy. And hope is not a foundation to have a strategy. So I do think there's some consequences associated with, at least on a fee structure basis, Tom. And not to just say that anybody would do this, but there is a potential for increased fraud in the network. If you think about it, if I'm used to dispensing a 30-day supply or a 90-day supply, and I'm getting paid $10.64 per dispense, what's to stop me from telling somebody, you know what, you're going to get it every 30 days? And then that $10.64 over time becomes $30 and some change. And so that's not to say anybody would do that, but business people are business people, and anybody wants to look at an edge. And I know that's a horrible thing for me to say, but not everybody is as honest as our jurist doctor, Dr. Westhill. So that's one potential repercussion in order to game the system. I always worry about stuff like that.
I think that's
Yeah, that's a
an
good
important
point.
call. We've been into this business long enough, Bradley, to see some of the bad actors, right? And when there's opportunities exist, there's the potential for fraudulent behavior. So we oftentimes there's a lot of voices in the crowd, right? So PBM has a voice, manufacturers have a voice, patients have a voice, physicians have a voice. What we don't hear enough of is from the plan sponsor, because oftentimes they're footing a majority of the cost associated with the health benefit. Um, Wes, would you offer any guidance to plan sponsors and how they get their voice heard when it comes to understanding the full breadth of these legislative changes?
Yeah, Tom, I think it's a really good call out. I think number one, employers should get in the habit, right, of tracking legislation that's going to impact not just their business operations. I think most employers are used to that. But I think now they've got to start thinking in terms of the benefits they offer to their employees, right? These are heavily regulated at the federal level, and I think most people are used to watching the federal space, but now we've got to watch the state space a lot closer when it comes to the prescription drug plan. I think because of ERISA, we talked about earlier, right, the concept of ERISA preemption. Most employers ignored what went on at the state level if they had a self-funded
Yep.
plan. There was no reason to monitor the state legislation. Now, due to the recent developments we've talked about, there is more of a reason to monitor that. So number one, I would say just be aware of this topic about regulating PBMs, regulating the prescription drug benefit, and that there is some room now to impact those self-funded ERISA plans where there was not room for that in the past. So number one, be aware. Number two, I would say just work with your advisors, right? If you identify bills that might impact your plan, as a fiduciary of the plan, right? Look into that, see how it will impact your plan, whether it's from a design perspective, membership coverage
Yep.
perspective, financial perspective. Dig in and find out what that means. And if you find out that it's negative for your plan, this goes now directly, Tom, to what you're talking
Yeah.
about, the employer voice. I think you've got to make contact with your representatives. They hear from pharma all the time. They hear from PBMs all the time. They hear from pharmacists all the time. They hear from providers, the health systems, the usual, right? The insurance carriers. Those are all the usual suspects who are there knocking on the door to talk to them about legislation, right? And that's good. They should be doing that. But now what we need is the employer also, right, reaching out, giving their perspective and the self-funded perspective of we pay the bill for the cost of care, right? And then saying, here's what this new policy, right, which might have a very noble aim. We talked about that. These policies usually do have a very noble aim, but here's what it's going to do to my plan as a small employer, trying to offer
Yeah.
great coverage to my people. So yeah, I would say track it, be informed, talk to your advisors, right, and then number three, make your voice heard. And just a great way to do it is to pick up the phone and call them, right? They get lots of calls. They're used to that. Writing letters is another way to do it. A lot of contact your local trade associations because they often band employers together, right? And they speak as a unified voice. So those are some ideas that I've seen work
And
in
that
the past.
advocacy is so important, right? Because it's just, I worked for the health plan previously. I've been on the Hill in Utah having discussions around preservation of benefits. You're hearing a lot from pharmaceutical manufacturers, patient advocacy groups. So, employer group plan sponsors being part of that discussion is vital.
Absolutely agree. And then just kind of circle back what we started off with. Um, I think we've done a good job of just really talking about how these reforms and investigations are really reshaping the pharmacy landscape, right? We're talking about as a potential to change reimbursement methodology and where costs would go there. Where can a patient get their prescription? Yes or no? There's a lot of outstanding items here. And Wes, I want to thank you for your time, in particular on this topic, because I think we could probably definitely have you back because it's always going to change. There's always something goes up there. Just like you mentioned, there are over 1,400 bills in the last year versus previous years. So, number one, I want to thank you for being our guest, and I do hope that you would like to join us back. Kangaroo story aside, but I think the salient thing that I learned from you today, and Tom, love to have your thoughts and Wes's thoughts, is that uh, where Washington, the feds hesitate, the states are having to jump in. And this 50-state strategy is creating concern for how do you manage this in aggregate, looking at everything, particularly if
Yeah.
you're a large PBM, a large employer group, or a large whatever that happens to spread throughout the nation. It's managing your own benefit as a plan has just gotten a little bit, dare say, a lot harder. So, Tom, what are your thoughts, your parting thoughts?
I couldn't agree more. Just that the level of complexity that that we're seeing, like Wes stated, 1,400 bills. And while you may say to yourself, they're just small iterations of one other, that's not generally the case. These are really complex bills, and truly trying to parse out what it means to a plan sponsor based on where your corporation is residence versus where your employee population calls home. These are all things that you have to take into account. So I would just say that this should be top of the list when we're talking about, what does my benefit look like next year, take into account new drug approvals, what does state legislation look like. I think these are all really important aspects to consider moving forward.
So, Wes, the last word on this topic. What's your parting thoughts?
Parting thoughts. I would say the issue that Bradley, you and Tom just talked about administering a plan in 50 states and following 50 different rules, that's the exact issue that ERISA was seeking to solve when it was passed 50 plus years ago. Um, so it's something to think about for policymakers as we move forward and, in an environment where a lot of us work remotely. Other than that, I would just say thank you for the invitation. I'd love to come back. And of all the kangaroo courts I've ever been in, this was my favorite.
Nice.
Awesome. Nice, man.
Full circle.
Glad that you're part of the team. You're an honorary pharmacist as well as a wonderful Juris Doctor. So for this episode of Farmland, I just want to, number one, thank our audience for listening. Without you, we would not be here. You are what make doing this a lot of fun and exciting for all of us. Hopefully I speak for Tom when I say that. But for this episode of Farmland, I'm Bradley Nelson.
Tom Davies.
And saying goodbye for West Hill, We're
The
farm,
esteemed West
the
Hill.
esteemed West Hill. We're wishing everybody a wonderful, wonderful rest of your day. Take care, and we'll see you next time on Farmland.